All right, the recording has started. All right, Assalamu alaikum. Masa al-khair. Welcome everyone to the Master Clinician online course. I am Ahmed Hani, the Academic Director of Tabbaba Medics. On behalf of all the members of Tabbaba Medics, I would love to welcome you to our online session today. Let me introduce to you Professor Imad Salah, a consultant internist at the National Guard Hospital, Kingdom of Saudi Arabia, Riyadh, a graduate of University of Khartoum. He got his MD from University of London, Fellowship of the Royal College of Physicians, Ireland, Fellowship of the American College of Physicians, and membership of the Academy of Medical Education, UK. The floor is all yours.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I welcome you all really to this very important talk. I can reassure you that what you're going to hear, number one, is going to, if you really grasp it well, is going to actually help you really move very fast in your career. And number two, unfortunately, actually a good amount of it is not in textbooks. These are actually new ways of practice, which have just come over the last few years, and they're not all available in textbooks for people to see. So I'm sure you will enjoy the talk. I would really like you to all mute your microphones, have a paper and pen handy, and by all means, document what you would like to document. If you have any questions, write them down. After each, we have 3 sessions. Actually, you are lucky in attending 3 sessions in one. So after each session, we'll have, just few minutes of questions and answers. And if there are many questions and answers, we'll leave them at the end. But I can promise you, you will have a highly enjoyable talk, and you will find it extremely useful and practical. It doesn't contain, lots of theoretical material. It's more of practical tips and how to actually deal with all the issues, right? So I welcome you again, and I'll start sharing my screen. If you have any questions, please just keep them for the end of the talk. Right. I hope that all of you can see the presentation. If Dr. Ahmed can confirm that, please.
Yes, it's clear.
It's clear. Okay. Now, the talk is about excellence or pillars of excellence for the expert house officer. But I can reassure you that, this applies to all actually grades of medicine, even for consultants, because some of the ideas are actually, as I said, they are new and they're not available in textbooks, right? And so it's good that people are exposed to these ideas, right? Now, there are loads of secrets actually in this talk. It's all about mastering the consultant role. This picture is about, an expert as a consultant, and this is a trainee, and they are seeing a patient. And the trainee is obviously trying to learn from the consultant. Now, the tips I'm going to share with you are actually about learning these skills fast. I'm actually a graduate of the University of Khartoum, but my interest in these things actually comes from the fact that I am responsible for the competency-based training committee, and therefore these are the things which we teach our residents in this, at the National Guard. Now, just admit them. Now, it's all about unlocking your brain power. These are simple tools actually that makes you actually very highly organized. Highly organized in the way you think, right, and the way you deal with and the way you deal with your patients, right? There is a book called The Secret, and if anybody has not read this book, I really would advise you to go ahead, right? And one of the things which actually in this book it says that by applying the knowledge of The Secret, they bring to light compelling stories of eradicating obstacles and achieving what many would regard as impossible, right? And actually, this actually also applies to the stuff I'm going to share with you. Right, to start now, there are 4 pillars that are necessary to achieve excellence in clinical care, right? These 4 pillars, right, I've put them all together so that you have that bigger picture of what actually constitutes excellence in clinical care. And I try to make them a bit clinical by actually using a heart failure case as an example. So I've used that case actually to interactively, show you how this case actually could be looked at and dealt with in a totally different manner than the classic routine way. Okay. Now let's talk about the first pillar. Now the first pillar is about just put this down here. The first pillar is about evidence-based medicine. So the first pillar, and we call these 4 pillars EQCP, the first is about evidence-based practice. Now, evidence-based practice is defined as the use of evidence together with patients' expectations, preferences, and values, and experience to come up with decisions. So decisions that are based on the 3 E's, evidence, expectations, and experience, actually constitute evidence-based practice. So the first pillar is evidence, right? Evidence-based medicine. The second pillar is quality. Now, quality is primarily deals with safety, but there are other components for quality. So quality-based practice also involves care that is timely, effective, efficient. There is no waste, equitable, equal, so that we don't treat any patient different to the other based on whether they've got the money or the race and so forth, and patient-centered, which means that the patients are actually the ones who actually are the major players. We avoid paternalistic medicine. So the patients actually are the ones who decide on their care. Now, the third pillar is competency-based practice. Now, competency-based practice, according to the CANMEDS, which is actually a competency-based framework, has 7 pillars or 7 roles. These are medical expert, advocate, communication, scholar, leader, collaborator, and professional. And the CANMED says that no clinician will be a competent clinician unless they are able to practice all the 7 competencies. So this is the third type of practice, which is important, for being a competent clinician. Now, the 4th practice is actually called patient-centered, and some people now call it person-centered, because even the person means not only the patient, but even it's the family and the healthcare provider. So some people call it person-centered practice. And there are also some elements which are of relevance to patient-centeredness, right, in decision-making, in choosing their treatment and so forth, right? And there are various elements of patient-centered care, right? So now, when I'm seeing a patient, I have to apply all these 4 practices, right? I have to be evidence-based. My practice should be quality-based, primarily safe practice. I should be a competent physician, and I should be able to apply all the competency roles, and I should be patient or person-centered. Now, these are the four domains of practice. Now, let me give an example of how you actually apply all the 4 domains in a single patient encounter. Now, evidence-based practice is about bridging the knowledge to action gap, right? What the evidence says and what we should be doing, right? Now, quality is about how to do it. Now, evidence tells me what to do. Quality tells me how to do it. And I'll give you an example in a second. And then the competency is about how I bridge the gap between the practice and how to do it, right? Actually, the personal part, the competencies that I need to do, I need to actually utilize to achieve this. Bridging the knowledge, practice, attitude, do gap. And if the patient-centered is actually bridging the patient-physician decision-making, so that the patient actually is the main player, as I mentioned earlier. The paternalistic medicine does not exist. Now, let me just give you an example to actually make you appreciate these 4 domains of practice. Now, in a patient with heart failure, with reduced ejection fraction, the evidence says, if I use spironolactone in these patients with reduced ejection fraction, I would improve their prognosis, okay? They can live longer. So this is the evidence. The evidence tells me what to do, but then how to do it in a safe way, how to initiate spironolactone, and the precautions I should use, and how to monitor the use of spironolactone. Actually, this is what quality-based practice is about. Now, the third element is competency. Now, I have to communicate with the patient, right, about the side effects of about what spironolactone is a type of drug, and what are the side effects, okay, and how to use it, and if you miss a dose, what should you do, right? And that I need to monitor you. Now, this is an important competency, and this is part of the communication role or communicator competency. So I cannot actually do the first 2 and not be good in communicating the use of spironolactone. So this is an important competency I have to use. And then the fourth competency, the fourth competency is, how I involve the patient in decision making, right? And there are now decision aids that can help patients decide, spironolactone, these are the good things, these are the bad things about it. And actually it's written in a simplified decision aid, right, that can help patients decide on whether I really like to have this medication or not. It tells how many people are going to be helped, how many people are going to be harmed, right? And therefore, this is what we call in evidence also, number needed to treat and number needed to harm. But we have to communicate these to the patient to help them make up their mind and decide to take the medication or not. Now, for the first time now, I am using the 4 practices: evidence, quality, competency, and patient or person-centeredness to achieve, excellence, right? So achieve excellence in care. So I have given them explicitly what I should be using. Right, now these are the initial 4 pillars of excellence, right? I'm aware of them, and now we're not going to go through, right, these 4 pillars of excellence, and I'm going to talk to you today about mainly the medical expert pillar, right, which encompasses obviously some of the competencies, also the quality-based and competency-based. Okay. Now, the first really talk is going to be about decision making. So how can I become an expert decision maker, right? They say that there is an agreement that the master clinicians possess 2 domains. These are cognitive domain or cognitive dimension, the ability to reason and decide appropriately. Now, clinical reasoning, critical thinking, clinical reasoning, and decision making are important cognitive domains for master clinicians. The second part is actually the human and interpersonal dimension, our ability to interact, the interpersonal, the behavioral part, how we interact with our patients and with our colleagues, right? Now, master clinicians, are expert in both. They are expert in critical thinking, clinical reasoning, and decision making, and they possess great human and interpersonal dimensions. They are able actually to interact and behave appropriately with patients, families, and their colleagues. Now, this is an important secret, and I am going to share this with you, right? Now, they looked at what is the difference between novice, for example, the house officer, right, and an expert, for example, the consultant. Okay, what makes the difference? What makes the difference between the novice and the expert, right? And they found the major 2 reasons are the ability of the expert to use the schemes of care and scripts of care. No, so what do we mean by a script and a scheme, right? Because these are the things which, differentiate the expert, the consultant, from the house officer, okay? The scripts take time to achieve or to acquire, right? But the schemes, you can acquire them and start practicing them as a house officer. As a matter of fact, my talk is about schemes, right? So that you actually use these schemes now as a house officer, or even as still early in your career. As a matter of fact, I tell my residents that I'm sharing with you schemes that it took me more than 30 years to master. I'm sharing it with you now so that you don't have to wait for 30 years to master, to use and master these schemes, right? Now, what is an illness script? Now, when you come across a patient, for example, with an acute appendicitis, or with a ruptured ectopic pregnancy, or with an acute asthma attack, you take the history and examination from the patient, and then, you do the test and you reach a diagnosis, right? Now, the whole story from the beginning to until you have actually diagnosed and treated the patient, this is a story which you keep in your mind as a script, as if you have written it in a textbook in your brain. In your brain, you have this experience. And so whenever you see another patient with a similar story, with the similar findings, right, you will quickly use this pattern which you have developed in your mind to recognize the patient illness, right, and decide on the medication and the management. Now, this is what is meant by an illness script. It's actually your experience of a similar thing, of a similar presentation that you have come across in the past. You've kept it in your memory, and you have, you just uncover it when you are seeing a new patient with the new history and examination findings. Right? This is your illness script. Now, and we call it as an example of a pattern recognition, because in your mind, you developed a pattern of a specific disease, and you actually apply that pattern, right? Just like comparing two photos. You compare two pictures or two images and say, okay, this one looks like the other, then it must be the same person. So this disease, this description, history, and examination look exactly like what I have seen before. So it must be a bronchial asthma or an ectopic pregnancy and so forth. Now, what is a cognitive scheme? Now, cognitive scheme is actually a map. It's a map which uses a mnemonic. Mnemonic, is like few letters which remind us of the important steps in recognizing or doing something, right? One of the commonest mnemonics we use actually in medicine is when, for example, we use the SOAP, for example, mnemonic for writing the follow-up notes. We use the SOAP, okay? SOAP is a mnemonic. The spikes, for example, for breaking bad news. Now, in medicine, there are loads and loads of mnemonics, but the important ones for everyday practice are very few. There are not many of them. There are not many mnemonics. Now, there are some schemes which actually, just like the mnemonics, right, which actually help you decide or, articulate a very organized, action. Your action will be very organized. You don't miss anything, right? We have lots of mnemonics and lots of schemes. A simple scheme which many people know about is, for example, people are coming to hospital with acute renal failure. And a simple scheme is, okay, it's pre-renal, renal, or post-renal. And then if you think renal, pre-renal, renal, or post-renal, you're unlikely to miss an important diagnosis as a cause of the acute renal failure. So cognitive schemes are cognitive aids. They help us make decisions that are smart decisions. And we don't forget, if we know the steps, we don't forget any important step. We don't forget these important steps. So illness scripts and schemes differentiate the experts from the novice or the juniors, right? The talk today is about cognitive schemes. We want people to acquire these cognitive schemes, right? And that can help them actually in their everyday practice. And believe me, they are extremely handy in the exams, right? Only yesterday, I was speaking to one of the senior doctors one of the doctors in Khartoum. And he said to me, I sat the exam, I didn't have to prepare a lot because I know the scheme. If they ask me about any question in the exam, I'll be able to answer because I know exactly what the schemes are and how to answer any question in the exam. As a matter of fact, and I have seen it time and time again, people who have learned the schemes and they come back to me and say they have been extremely handy in the exam and they helped us pass the exam. Right. Now, I'm going to share with you this clinical case, right? And this clinical case, I will use it actually, as a matter of fact. I will use it as a matter of fact to illustrate how to use the schemes, right? Now, this is a 66-year-old lady. She was admitted mid-November 2018. Her complaints were that she was breathless at first. This is her fourth admission. Her fourth admission to the hospital since 2018. Most of the time she stays her average length of stay was 11 with a range of 6 to 22 days. Now, her major issues were severe global heart failure evolving over 9 months. Her left ventricular ejection fraction is 40%, and this is considered a moderate reduction in her left ventricular ejection fraction or systolic heart failure. She has a background of diabetes and hypertension. She also has dyslipidemia. She already had ischemic heart disease and had a stent put in one of her coronaries, the circumflex. And she presented with symptoms of orthopnea, paroxysmal nocturnal dyspnea, and lower limb swelling. And obviously, for medicals people, these are the classic terms that we use for people with heart failure. Orthopnea means that they are breathless when they lie flat. Paroxysmal nocturnal dyspnea means that they wake up at night really breathless and with lower lymphedema. Now, she also noticed that she was febrile. She took her temperature at home and she noticed that it has gone up 38.5 degrees Celsius. She noticed that her sputum was red colored and she was coughing up blood or red colored sputum. Obviously, in the history, we just say exactly as the patient has said, I noticed red colored sputum. She also had noticed some right lateral chest pain with coughing. So when she coughs, she noticed also right-sided chest pain. Now, she admitted that she misses her diuretics because her diuretics made her incontinent of urine. And she said that I have been so ill that I have been actually homebound, haven't been able to visit, my sons or daughters because they have been that unwell. Right. Now, when on examination, she was breathless, she had warm extremities, she was confused, her oxygen saturation was on 2 liters was good, 95%. Her blood pressure was 146/78, heart rate was 110, respiratory rate 22, she was febrile. So you can tell that she had abnormal vitals. The blood pressure was on the high side, the heart rate was high, the respiratory rate was high, the temperature was high, right? And she was breathless. She had good signs of heart failure with reduced jugular venous pressure. She had a Gallop rhythm. She had bilateral late inspiratory crackles and she was wheezy. Now she had bilateral pitting symmetrical lower lymphedema, and the initial test showed that her X-ray was clearly showing pulmonary edema with bilateral plurieffusions, and she had a high urea and a high creatinine. The sodium was on the low side and potassium was normal. Right now, if you look back through this case, you see that how complex are the history and how complex is the examination. Right now, we want people to be experts in articulating the history and examination in a very professional, high caliber manner. And I'll show you how such a very long and complex history can be actually summarized expertly using simple rules, right? And I'll tell about the rules. Now, unless we do things properly, we are likely to have medical errors in our practice. Now this lady is so complex right? And so many issues, okay, that if I do not have a proper management plan, and that management plan is comprehensive, I'm likely to miss something, and my input would be of low quality, and maybe I will end up with some medical errors, right? And specifically, if the system is not prepared to deal with such complex patients, then we end up actually making mistakes, because if we rely primarily on our brains. Now, if our brains are going to work well or not. So there is a way to make our brains work perfectly well, okay? And why our brains don't work perfectly well all the time? Very simple, right? Because we are like as human beings, we have lots of things can stop us actually doing things absolutely correctly every time, because we get interruptions, phone calls. We might even have a full bladder and don't want, so busy, can go even to empty our bladders. There might be some home stresses. There might be new multitasking, hunger, violence, ambiguity, short staff, technology, loads of things that actually reduce our cognitive abilities, and therefore we might end up actually making mistakes. So we need some tools to help us reduce the possibility of missing an important intervention. So how to achieve excellence, right? So we are going together to go through a comprehensive management plan using schemes which stops us actually having any mistakes, without making any mistakes, right? So we're going to go through these steps. Okay. Right. Now, the 7 steps, these are called the 7 golden steps. Now, these are the 7 golden steps which you can do in any specialty, in any acute admission, right? And they work perfectly well. The first one is you gather your information, and that's obviously the history and physical. Now, experts take history that is patient-centered, hypothesis-driven. Now, patient-centered means I will ask the patient not only about the symptoms of his disease, but I will also make sure that I find the impact of the disease on his life. Cannot work, cannot go to the mosque, cannot look after themselves, right? They say that if you have to be a good patient expert, patient-centered physician, you have to make sure about having a patient. You ask about what also matters to the patient, not only what is the matter with the patient. Can somebody mute their thing? And then the other thing, you have to take a history that the hypothesis-driven one means that you ask relevant symptoms and signs to your proposed diagnosis. For example, if you are, worried about, for example, acute, ectopic pregnancy or ruptured ectopic pregnancy, you ask about missed period and bleeding PV and so forth. Okay, so this is what is meant by having a hypothesis-driven history and physical exam. So people who do patient-centered and hypothesis-driven are the ones that are actually the master clinicians. Patient who only focus on what is the matter with the patient, what's the diagnosis, these are not taking a good history, and experts actually use hypothesis-driven history taking. They think of a specific diagnosis, they ask relevant points in the history, and even when they examine, they look for the relevant signs. Now, the second important step is actually summarizing. Now, using something called the technical language, and they don't put any negatives there. They put technical language, and I explain exactly what technical language is, right? Because one of the major differences between juniors and seniors is that seniors are able to articulate a fantastic technical language summary, right? And if a junior cannot articulate if If a doctor cannot articulate a technical language, a summary using technical language, then they are unlikely to provide the right summary which mirrors what the textbooks say. The textbook says patients with heart failure come in with orthopnea, paroxysmal nocturnal dyspnea, and so forth, right? So these are the technical language for the disease. But there is another domain to technical language, which is something called the conclusive technical language, right? You read orthopnea and PND, the conclusion is that the patient has heart failure, okay? So you summarize using conclusive technical terms or technical language using the conclusive terms. The third element is put the right diagnostic label. Now, many people, you will see that they fail actually to articulate a comprehensive diagnostic label. And additionally, they fail to put a problem list. You cannot manage a patient without putting a comprehensive diagnostic label and a problem list. You have to have these for a holistic input. Holistic means comprehensive. You do not miss any part. You give the patient a full package of care. You have to put a differential diagnosis for every patient. Now, this fourth step, this is what takes the doctors to court, because they don't think of a differential diagnosis, they miss a diagnosis, and therefore they take them to court, right? And this is something, unfortunately, which is always missed, and therefore people have to know how to put a differential diagnosis, right? The fifth element is ordering tests rationally. Now, rationally, you tell people, why are you choosing, for example, for this patient with heart failure, would you use a brain natriuretic peptide to diagnose heart failure or not? Would you use CRP, for example, to diagnose pneumonia, or the white count, which is better, the CRP or the white count, right? You have to have a way to decide rationally what is the right test to do. And there are, again, simple tools to help you decide what is the rational test that you should do. What is the right test I should do? I should not do the test that is not going to help me, okay? Or the more expensive test, when in fact there are cheaper screening tests. And then the immediate therapeutic intervention. And we have actually looked at both juniors and seniors and asked them, this is a case, what are your therapeutic interventions? And consistently, people missed one or two elements of the therapeutic interventions. And we now have a scheme so that they do not forget any of the important immediate therapeutic interventions. And then preparing for discharge. And again, if we tell juniors, how do you prepare for discharge? They usually don't have a good clue of what they should do. And there is a very simple scheme which tells them exactly how to decide on the day of admission. As a matter of fact, on the day of admission, you can start preparing for discharge, and therefore you don't keep your patients in the hospital for long, okay? So now we'll go through these, in details. And I just want to share with you a very important, actually, something which we are very proud of. Our schemes that I'm going to tell you about have been accepted at the Canadian Medical Education Journal. They found them extremely useful, and they have been accepted, and we are just waiting for our article to come up in the next few weeks. So what I'm going to tell you is just about coming up in the literature. So that's why I'm saying it's not yet available in textbooks. So you will come across it, because these are new stuff which has come out of experience and out of training in competency-based education. Now, the first one is gather history and physical. So this, as I mentioned, should be patient-centered and hypothesis-driven. The second is summarizing using technical languages and coming with conclusive terms. The third thing is using something called the diagnostic label. And for the diagnostic label, we have something called the BESS, and I'll explain it in a minute. BESS stands for the bedside diagnosis, etiology, and severity, right? And we use certain schemes to make a diagnosis, something called pattern recognition, something called rule of thumb, something called ruling out the worst case scenario, and another one called the red flags. And then the fourth element is putting a differential diagnosis. And we have a scheme called the APP scheme, anatomical, physiological, and pathological differential diagnosis scheme. And believe me, this is a very simple scheme, actually. And you ask And I even just recently asked one of the doctors, right, what is the differential diagnosis of this particular patient who's coming with a stroke, right? He came with a stroke, right, and or a hemiplegia, and therefore I asked the resident, what is the differential diagnosis? And because she did not use the APP scheme, she actually missed quite a few of the reasons why the patient developed hemiplegia, right? The fourth or fifth step is actually ordering tests rationally, right? And we use something, the sensitivity and specificity schemes, and there is something called the AP scheme, which is absence of an alternative diagnosis and presence of strong risk factor to decide what is the pre-test probability, right? Unless you know the pre-test probability, you are unlikely to decide what is the best test, because the pre-test probability of a diagnosis tells you what is the right test I should be using. The sixth step is called the immediate therapeutic intervention. Again, there is a very simple scheme called the 5S scheme, which tells people what exactly to do. The scheme for discharge is called the ACT scheme, right? ACT. And I'm going now to explain everyone in details, right? By all means, just use your, by all means, if you want to write it down, if you want to ask any question about them, you are welcome. Right, so we have 7 steps for expert decision making for master clinicians to become consultants in a very short while. The first one is to gather information. This has to be patient-centered, hypothesis-driven. The second one is you have to use technical conclusive terms to write your summary, because this actually mirrors your illness script that you have in your brain of what you have heard, what you have seen, or what you have read in the textbooks, right? And then the third step is make a comprehensive diagnosis, and we have a scheme, it's called the BEST scheme, and I explain exactly what it is. And we have pattern recognition, rules of thumb, rule out worst case scenario, red flags, and deductive ways of thinking to reach a diagnosis. The fourth step is we use a differential diagnosis scheme so that we do not miss diagnosis, right? This is the differential diagnosis scheme. And we have 3 ways, the pathological, anatomical, or physiological, and I explain this in a minute. Then we order tests based on our pre-test probability. If the pre-test probability is high, then we go for a specific test. If the pre-test probability is low, we go for a sensitive test. And I'll explain what's the difference between what is a sensitive test and what is a specific test. And then the sixth step is the 5S scheme. And this is the thing which you're going to use most of the time for every patient. It's called the 5S scheme. And the last one is the ACT scheme. You want to prepare your patients to go home sooner than later. You don't want them to stay in the hospital and spend all their money if it's a private hospital. Okay. Now, we go through the steps. The first one, gathering information, right? The first one is history and physical, right? The first one, it has to be patient-centered or family-centered. We focus on the disease, yes, what's wrong with the patient, but what matters to the patient? What matters to them might be the money. They don't have the finances. We really have to find out so that we are able to help them, okay? So they cannot go to work, they cannot earn money. Okay, they cannot do things that they love to do. So, and they say in patient-centered care, people should focus on both what's matter with the patient and what is the matter with the patient, right? Both of them. And then the second thing is, as a matter of fact, we were sharing in one of the two clinicians, right? Who just did, I think, Lina and Abrar, and they used actually this, what matters and what matters to the patient and what's the matter with the patient, right? The second thing is hypothesis-driven. You focus on the symptoms and signs relevant to your suspected diagnosis. As undergraduates, medical students, we just go through the symptoms. Do you have a cough? Do you have a fever? Do you have, shortness of breath? Do you have lower lymphedema? But after graduation, we have to be hypothesis driven. So we ask some symptoms of relevance to what we think is a diagnosis. right? What matters to the patient, how did your illness stop you from doing something you regularly love to do? What is the matter with the patient trying to reach a diagnosis? For example, if you think of some Legionnaires' disease, somebody who's traveled abroad, usually doesn't happen a lot in our hot countries, but have you been traveling abroad recently or staying in a hotel if you are suspecting Legionnaires' disease? Right, so this is what is the matter with the patient. This is what is the matter with the patient, the physical component, the social component, the psychological component, and the patient also like people to be professional and empathetic and give hope and so forth. So this is also what matters to the patient. Now, going to the second part, how do I summarize like an expert? I want to summarize just like an expert, my history. My history might be 300, 400 words, but I want to summarize it in less than 15 or 20 words. So how can I do this? Now, we usually put in the summary, right, patient's name or gender, age or occupation, nationality. These are important demographics. We put them. But then when we go to and we say the patient has presented with these symptoms, okay, and for how long they have been. But then when I go further, these things are actually not, I don't actually change a lot in them. But now look what happens when I start summarizing in technical language. When the patient had a pulse of 130, I don't summarize and in the summary I say on examination the patient had a pulse of 130. No, that doesn't apply. I have to say that the patient was tachycardic. Now, if I examined his tummy, his abdomen, and there was shifting dullness, on my summary, I don't say he had shifting dullness. I say he had ascites. If he had large fine bibather crackles, I don't say he has on examination in my summary, but he has bibather crackles. I say he has pulmonary edema. If that obviously patient is a cardiac patient. Now, if a patient I notice that they are, covering their face and they don't want to face the light, right? I don't say that the patient on examination, he was actually covering their face and they are avoiding light. I say he has photophobia. And this is what differentiates the expert from the novice. The expert is more likely to actually summarize the technical language. And this is actually have been found by research that actually compared to juniors or novice doctors, right? The more senior people are able to summarize technically, right? And actually, very just textbook line. And obviously, I didn't put here, but it's important that you also include the psychosocial impact. And that gives a feeling that you are dealing with a human being. You are not dealing with a disease. You are dealing with a human being, right? That this patient has some psychosocial impact. They cannot, for example, go out. Okay, now this is actually the history that I showed you earlier. And you can see that it's so complex and long. Okay, it's how many words, and the fever 38, red-colored sputum, right lateral chest pain with coughing, misses her diuretics, homebound. Okay, and now let's see that in a very small paragraph, I have actually summarized 2-3 pages of history. Now I put here. We like people to call people by their names. They shouldn't say 66-year-old female. No, they should say Mrs. or Mr. or some people use nicknames. Even this is better. With a background, 66-year-old with a background of ischemic heart disease, post-standing in 2014, heart failure with reduced ejection fraction, type 2 diabetes, hypertension, dyslipidemia. Now, she said that this was his fourth admission. I interpreted recurrent admissions, right? Now, she presented with symptoms of congestive heart failure, hemoptysis. You should, instead of saying that she presented with orthopnea, BND, and lower lymphedema, I can just say she's presented with symptoms of congestive heart failure, right? And hemoptysis, this red-colored sputum. She had chest pain when she coughs. Pleurisy. Now she has poor compliance. She was missing her medications. I wrote poor compliance and significant social impact because she stopped going out. You see, now I have used very high level, technical language and interpretation of all the salient features of her illness. clinically, I don't write that her blood, she will have warm extremities. No, hemodynamically stable. She's febrile because temperature was high. She's delirious because she's confused, right? Confusion means acute confusion state. She's delirious, right? Her blood pressure was 146, so I don't write it up. I say uncontrolled. She's breathless. She's tachycardic. Now she's wheezy, means that she has bronchospasm. And she has just signs of failure because she had raised JVP and a gallop rhythm and bibasal crackles, right? And she had, low lymphedema. So I can write that, and she has signs of biventricular failure, okay? And from the investigation, she's mildly hypernatremic with impaired kidney function. You can see now in front of me, I have an unbelievable information that I need to work on and sort out all the issues. I have it all in one small paragraph. If I cannot master the ability to write a technical summary, I'm likely to miss important elements in the diagnosis and management of this patient. Now we go to the third component. Now I want to document a proposed diagnosis in a guideline-friendly, evidence-based way. So what does the evidence tell me when I put a diagnosis? What are the elements of a diagnostic label, right? So before I go to that, actually, I share with you something which, again, is a collection from several resources, is not from one. And this is actually how people reach a diagnosis. And as a matter of fact, I asked my residents, how many ways we have to reach a diagnosis? I found nobody who knew all of these. I found no physician who could tell me from our trainees how many ways we use to diagnose a patient, right? They say, well, we know, for example, we know one way, for example, we know, for example, pattern recognition, okay? But what else? How do we reach a diagnosis, right? And I'm going to share with you these 10 routes, 10, right? The first one, just put it there. The first one is pattern recognition. And this is the easiest part, right? If you see somebody with shingles, the spot diagnosis, come on, this is spot diagnosis. Shingles are acromegalic phases, this is spot diagnosis, okay? This is called pattern recognition. This is one simple way of diagnosing. This is spot diagnosis, okay? Or the classic, you see the ECG, and this is the ECG exactly shows, right? The ECG shows the typical changes of somebody with acute MI, right? This is again called pattern recognition. So the ECG is a pattern recognition. The other way we diagnose is actually, we call it the rules of thumb, right? The rule of thumb, for example, somebody coming with early morning headache and vomiting, you think of increase in the blood pressure. This is the rule of thumb. A lady who misses a period, a married lady who misses a period and then comes in with lower abdominal pain and some PV bleeding, this is a rule of thumb. This is ectopic pregnancy. A patient who comes in with, central abdominal pain, going to the right, iliac fossa, and causing a bit of vomiting and anorexia, come on, this is acute appendicitis. These are called the rules of thumb. Okay, so we have two simple rules, pattern recognition and rules of thumb. Right, the second one, the third reason, we use something called ruling out the worst case scenario. And now this is a secret of excellent top-class ER physicians. Emergency room physicians, if somebody comes in with central chest pain, right, they don't think first of esophageal spasm or heartburn. They think first this is an acute MI, right? They rule out the worst case scenario first. They think of the worst case scenario and then think of the others. So they put a differential diagnosis based on the seriousness of the disease, right? So this is another route for making the right diagnosis, ruling out the worst case scenario. The fourth way of reaching a diagnosis is through red flags. So what are these red flags? Red flags mean the presence of symptoms or signs that make a serious pathology, a serious cause, more likely. But if somebody comes to me with low back pain that's associated with retention of urine or incontinence of urine, right? Or neurological changes in the legs, right? I don't actually just label it as, come on, this is a simple disc prolapse. No, I have to think of more serious pathology, especially if there are rest pain, weight loss, okay? These are called red flags. But if somebody comes to me with a headache and they lost vision, now this is not the same as somebody coming to me with a headache and they are chatting and nothing else is wrong with them, right? So red flags tells me that there is something is wrong. So ruling out the worst case scenario and red flags are another way of actually reaching the diagnosis. The other way is actually using hypothetical deductive strategy. So when you cannot reach a diagnosis, you keep asking points in the history to find out. This is called just like a police officer, right? Trying to find out exactly all the details. And one other way of actually we use to reach diagnosis, we use medical calculators. I don't know whether this is SLE or rheumatic fever or there is a pulmonary embolism or DVT, right? And medicine is full of calculators that you can use them to reach a diagnosis. We use medical calculators, right? Obviously, all of us use investigations, right? But there are other ways we use to reach diagnosis, not only investigations. We have medical calculators, hypothetical deductive strategies, ruling out the worst case scenario, red flags, rules of thumb, okay, spot diagnosis. We have lots of ways. Now, let me just tell you some secrets. You have done all these, but you cannot reach a diagnosis. And this actually, things which not many people know about, right? Now, consult. Not many people consult when they are stuck and they cannot diagnose. By all means, you either consult a colleague or present your case in a medical meeting, right? And then you can get the diagnosis. Another tip, and I can tell you, right? Some people say, well, Dr. Hassan Dr. Imad is a good diagnostician. I tell you, when I got stuck, I go to PubMed. I put all the important points in the history or examination or investigations, and I search in PubMed. And I tell you, I did that, and I got a diagnosis for a patient that actually was missed for a long time. Okay, just by going to PubMed and putting actually all the important bits about the history, examination, and investigations in PubMed, and I got it. Right, and obviously there is another route for treating patients, which is for reaching a diagnosis, therapeutic trial, and as usual, either an antibiotic or steroid. We are not allowed to allow a patient to die without a trial of TB drugs. Now, this is a rule in Sudan. The patient coming with unexplained fever, weight loss, you give him a trial of anti-TB, okay, or a steroid trial if you suspect an inflammatory disease. And again, we have used it in our practice. So we have actually 10 routes for diagnosis. The first one is pattern recognition. The second one is the rule of thumb. The third one is ruling the worst case scenario. The fourth one is asking about red flags or finding about red flags. The fifth one is about hypothetical deductive strategies. The seventh one, medical calculators. The eighth one or the seventh one, investigation. This is what we do. But there are simple things before even doing the investigations. You can use a medical calculator and so on, right? And then the eighth one is consultation. Ask your colleagues, help. Your colleagues can help you. PubMed, when you're stuck, just search it in PubMed or use a therapeutic trial. So these are the 10 routes. Right. Now, pattern recognition, rules of thumb, ruling out the worst case scenario, red flags, hypothetical deductive strategies. Now, this is a spot diagnosis. You see shingles and acromegalic spot diagnosis. This is, spot diagnosis, pattern recognition, high fidelity, spot diagnosis, right? Rules of thumb, I gave you the example of early morning headache and vomiting. Somebody coming with a headache, right? We don't think of, somebody coming with headache. I always think of the more serious things like severe hypertension, meningitis, subarachnoid hemorrhage, temporal arthritis, right? If somebody comes to me with back pain, I always try to think, right, are there red flags or not? Is it rest pain, weight loss, neurological deficit? Okay, right. Hypothetical deductive is when you look for a detailed history and you get clues from all the components of the history and you do a comprehensive physical exam. You might need to do tests or you might need to repeat all the steps again to reach a diagnosis. Now, the secret of labeling, giving a patient a diagnostic label. Now, and this is what really I find really something which it happens so frequently. You tell a patient, you tell the resident or the trainee, what's the diagnosis? He tells you this patient has asthma, but asthma is not a diagnosis. And ask them, what this patient has? This patient has a stroke, but stroke is not a diagnosis. Stroke is a manifestation of a problem. You cannot say patient has heart failure because heart failure is a manifestation of a problem, right? Heart failure does not come by itself. It has something which brought it up, okay? So people tell, when you ask them about a diagnosis, they give you the bedside diagnosis, but they don't go further and tell you the etiology. And even worse than that, they don't try to give you a severity score. Now, all guidelines tell you that if a patient comes into you, whether it's heart failure or stroke or asthma, you have to identify the 3 elements to give a comprehensive diagnostic label. You have to put what you think is wrong with the patient, what is the etiology or why it happened, and what's the severity. Now, I'll just give an example. You see a patient with cough, fever, and X-ray shows pneumonia, and you say this patient has pneumonia, right? And you don't think of what's the cause of his pneumonia, the etiology, or what's the severity. How would your management be? It will be totally deficient. Because if you said the etiology is corona, it's different from if you say the etiology is influenza, or if you say it's pneumococcal pneumonia, or even tuberculous pneumonia, okay? Unless you try to force yourself to think about the etiology, your management will definitely be incomplete. And again, if you don't put the severity, the guidelines say if a patient comes in with community-acquired pneumonia, you have to put a CARB score so that you know, can I send them home or send them to hospital or even send them to ICU? Because the CARB score decides exactly how to manage. Right now, if you really think about it, you will find out that the majority of clinicians, when they put a diagnostic label, they fail to put a comprehensive diagnostic label. Right? The bedside clinical diagnosis is actually the diagnosis that would explain the symptoms and signs. So the patient has come with pneumonia. The etiological precipitant, what is the cause? For example, he came in with COVID pneumonia. The severity, how bad it is. Now, if you look in medicine, every disease has actually a severity score. The care for pneumonia, care for acute coronary syndrome and heart failure, Glasgow Coma Scale, Krupp score, Apgar score, Blatchford score for upper GI hemorrhage, Ransom score for pancreatitis. You know, the guidelines are clear. You have to put a severity score to know exactly the prognosis and how to manage these patients. Okay. If you don't consider the precipitant or cause, in addition to the clinical diagnosis, you will inevitably result in deficient care input and poorer outcomes, right? Now, again, you need to actually decide on the severity because the treatment changes and even the sites of care. And I gave an example of care. Now, care tells you where is the site of care, and therefore the right immediate interventions, right? So, unless you have a complete diagnostic label with bedside etiology and severity, your management would be deficient, right? A patient with asthma exacerbation, the diagnosis is asthma exacerbation. But if you write that the etiology was poor inhaler technique and the severity is life-threatening, the management is now totally different, right? Poor inhaler technique, I have to train on inhaler technique, otherwise they will keep coming to hospital. Or life-threatening asthma, the management is totally different, right? The site of care has changed, the severity for life-threatening asthma has changed. And want to prevent readmission, I actually have to think of other, I have to train on inhaler techniques. Right, if I don't put a problem list, my input will be deficient because I will miss working on their other issues like diabetes and hypertension, and even the poor compliance, how to improve their compliance, right? Now, the fourth step is actually the differential diagnosis. And now, many people actually, if you ask them a differential diagnosis, because they don't have a scheme in their mind, they actually try to erratically find a group of a differential diagnosis. And this, unfortunately, will end up them missing some of the differential diagnosis. We have three ways of putting a differential diagnosis. It's called the APP scheme, the anatomical, physiological, and pathological. And many doctors misdiagnose because they miss this fourth step for differential diagnosis. The anatomical is for pains and swelling. You know, if there is pain, the differential diagnosis anatomical. Central chest pain, the anatomical. You know, the thoracic cage, or the esophagus, or the heart, or the pericardium, or the neurogenic. So, you know, pain syndromes, actually, the differential diagnosis is anatomic. Similarly, the swellings, the neck swelling, actually differentiated anatomically. This is thyroid, lymph node, vascular, skin, and so forth. Physiological is used for 2 or 3 elements, like shock. Shock is actually the differential diagnosis is physiological, like hypovolemic, distributive, obstructive, or cardiogenic. And thrombosis, similarly, is actually related to vessel wall, pathology, blood constituents, or flow rate. These are physiological differential diagnosis, right? Now, the one which we use most of the time is the etiological. You know, as a matter of fact, in the exam, you are asked for something which is not for the anatomical and not for the physiological. This is what you need to be saying. Is it congenital or hereditary or acquired? So traumatic, infective, inflammatory, vascular, neoplastic, metabolic, drug-induced deficiency, psychogenic, and idiopathic. Unless you actually, as a matter of fact, if you are asked about any differential diagnosis, if you go about these 10, you are unlikely to miss any important one, and you will scare the full marks. Now you want to order the right test. You don't want to order test erratically. You want to be smartly choosing the right test, right? Now, to choose the right test, you really have to decide first the probability of the diagnosis, right? If the probability is high, you go for something called a specific test. If the probability is low, you go for something with a test which is a highly sensitive or sensitive test. Now, how do you do this probability? A very simple technique. You ask yourself, is there something that can explain the symptoms or signs, right? And there is a strong risk factor. I'll just give an example, right? Now, I get a woman, for example, of 50, right? And she has just, or say 40, she has just delivered. She has just delivered. And now she's coming to me with pleuritic chest pain and breathlessness, right? And she also had a bit of fever. Now I did an X-ray, and the X-ray is normal. So there is no pneumonia, right? Now, how would I rate her AP? So on the X-ray, I cannot find an alternative diagnosis to what I was thinking of, which is possibly pulmonary embolism. Okay, she's a per-perium lady, right? She's per-perium lady. So, and the X-ray does not show pneumonia. And she has a strong risk factor for PE. Right. Now, if my answers to both of these are yes, I cannot find an alternative diagnosis, this is yes. And there is a strong risk factor, this is yes. So when both are answered yes, this is considered high probability for pulmonary embolism. If it's intermediate, if one is yes, one is low, there is low probability, intermediate probability. And if both are no, there is low probability. Now, let's give it in another example. Now, if I have a young man, right, who is having a flu symptoms, and he's coming to me with pleurisy and shortness of breath, right, and a bit of fever, exactly the same symptoms as the 40-year-old lady who has just delivered. Now, I did the X-ray, and I found a small patch of pneumonia. Now, this answer would be yes or would be no. It would definitely be no. Why? Because there is an alternative diagnosis. Okay, I can see on the X-ray an alternative diagnosis. Presence of a risk factor, strong risk factor for PE, no. So both are no. So this is low probability. Now, the first patient, right, high probability, I will use a specific test, which is likely to be, CTPA, CT angiography, for example. And the second one, I would do a highly sensitive test, which is a D-dimer. And now I'm going to, in a minute, explain to you why I'm using the highly specific test in the first patient because my answers were both yes, high probability, and why I'm using the D-dimer, which is a highly sensitive test in the second patient, right? There are two other ways of actually reaching a probability. One is scoring tools. Obviously, we have the Welsh score, and another one is prevalence rates. For example, I gave this example. Now, if most patients coming with the flu in the ER, 80% of them end up actually having COVID, then the pretest probability would be 80%. Right? If a patient comes during the COVID epidemic, and they have actually 80% of them end up with a positive COVID test, then the prevalence rate would be 80% in patients with flu, right? These two tools also help me decide the pretest probability. Is it high or low? Because a high pretest probability means I'm going to request a specific test. A low pretest probability means I'm going to send for a sensitive test. Now, let me explain a bit more about specificity and sensitivity and likelihood ratio, and I'll make it as simple as possible for people to grasp. And don't worry if you cannot grasp it very easily, because these are concepts that are sometimes difficult to grasp. But I'll make it very easy for you. Tests are classified either sensitive or specific. Now, a sensitive test means that it is likely to be positive in so many diseases, not exactly in one disease. If a test will be abnormal in so many diseases, you can be reassured that it is a sensitive test. For example, the ESR can be high in so many diseases. This is a sensitive test. Similarly, the CRP, similarly, an increased white cell count, right? They are not specific for infection. They can be high in so many diseases. That's why they are sensitive tests, right? A test like a spiral CT or a CTPA, right? Or a troponin test, right? Or a Doppler for a DVT, right? Or an ECG with ST elevation. These tests, right, are inclining more towards specificity because they are more likely to denote a specific diagnosis. Okay? So when a test is positive in so many diseases, right, then it is likely to be a sensitive test. When a disease is only positive in the specific, it is in a single entity is a specific disease. Now, you will not find a double-stranded DNA positive, for example, in a patient without, in other diseases other than SLE. It's likely to be specific for SLE. Similarly, the anti-CCP, the cyt-related polypeptide for the rheumatoid arthritis. While ANA, anti-nuclear antibody rheumatoid factors, are actually positive in so many diseases, right? Other than SLE and rheumatoid arthritis, that are sensitive. So the concept of sensitivity means that a highly sensitive test means that it is likely to be positive in so many diseases. A highly specific test is likely to be positive in its specific disease only, right? And the rule is very simple, right? If the pretest probability is high, you go for a specific test. If the pretest probability is low, you go for a sensitive test. I just give you another example. Now, the tuberculin test is a highly sensitive test. It's not a specific test because the tuberculin test is positive only in so many disease patients, even without TB, because it is, people with, exposure to environmental mycobacteria will have a positive tuberculin test. Okay, so the tuberculin test is a highly sensitive test, right? While acid-fast bacilli is in the sputum test, or is more likely, or PCR for sputum, or quantiferon are more specific tests. So if I have a low pretest probability, right, I won't actually do acid-fast bacilli. I will just do the tuberculin test as a screening test, right? But if I suspect strongly the diagnosis, the patient is coming with a cavitatory lung lesion and cough and hemoptysis and sweating at night and loss of weight and anorexia, come on, tuberculin test is a waste of time. Just go for a sputum for acid-fast bacilli because you need a specific test, right? Now, the sensitivity and specificity are combined in something called the likelihood ratio, right? And the higher the likelihood ratio goes with the highly specific test. The more the highly specific test, the higher the likelihood ratio. A very simple rule. A test that is highly specific will have a highly likelihood ratio for diagnosis. Okay, a very simple rule. Right, now to remember how to use a specific or a sensitive test, a very simple rule. There's something called SNOUT and something called SPIN. Now, SNOUT stands for in a highly sensitive test. If the result is negative, you can be reassured that you have ruled the disease out. Okay, just give an example. Now, I said that a patient actually, with, for example, fever, with fever, and he's coming with fever, right? And I suspect, for example, infection like pneumonia, okay? And I use a sensitive test like the CRP, right, which is a highly sensitive test. The white cell count is not a good highly sensitive test. It's a moderate highly sensitive test, but the CRP or infection or inflammation in general is much better. Now, I suspect pneumonia, and I do the CRP, and it's a highly sensitive test, and it comes as negative. So it's normal. I can then rest reassured that there is no way that this patient can have community-acquired pneumonia because the CRP is a highly sensitive test, and if it is low, it makes the diagnosis unlikely. It's called SNOUT. A highly sensitive test, if it's negative, rules it out. Okay, I don't need to give antibiotics because the CRP is normal. Okay, chest X-ray is also, I don't need to do chest X-ray because the CRP is normal. As a matter of fact, they use it in primary care for somebody with COPD and they come with increasing cough. They do the CRP. If it's negative, they don't give antibiotics. That's it. You don't need even to do a chest X-ray. So CRP is a highly sensitive test. The same thing, another highly sensitive test in medicine is the BNP, brain natriuretic peptide. Now, the brain natriuretic peptide is a highly sensitive test, right? So it is useful when it is negative, because if I suspect heart failure and I do the BNP and it's negative, it rules it out. So the good thing about sensitive tests, they are useful for screening and they are useful for ruling out the disease. Okay, I can use tuberculin test as a screening test, and if it's negative, I can say patient doesn't have TB or exposure to mycobacteria. If I do the BNP and it's negative, I can rule out heart failure, right? Unless the patient is very obese, because obesity can give you a falsely low BNP. But in general, right, highly sensitive tests are useful when they're negative. So when I suspect a diagnosis, for example, I saw a patient with pains in the joints and things, but she doesn't fulfill the criteria for rheumatoid or SLE. So the scoring for rheumatoid or SLE are low. Will I do the ANA, antinuclear antibody, or will I do the double-stranded DNA? If the pretest probability is low, I will do the screening test or highly sensitive test. So I will do the ANA because the scoring tools tells me that the probability is low. Now, if I do the test and they are negative, I can say this patient does not have rheumatoid or SLE. But if the test is positive, then I have to go for a specific test because the sensitive tests are useful when they're negative, not when they're positive, right? If I do a BNP or a CRP and they are high, I have to have the X-ray. If I do the D-dimer, which is a highly sensitive test, and I find that it's actually negative, I can just forget about a spiral CT. But if I do the D-dimer and it's positive, then I have to go for a specific test because sensitive tests rule it out. So SNOUT, and the one for specific tests are SPIN. So a highly specific test, if positive, halas, confirm the diagnosis. If I do spiral CT and it's positive, diagnosed PE. If I do double-stranded DNA and it's positive, diagnosed SLE. Okay, so these are highly specific tests. They rule in. So I have to know the SPIN and SNOUT. For every, if I know the test is sensitive, it is useful when they are negative because of SNOUT. If a test is specific, I know that it's useful when it is positive because it rules it in, SPIN. Right? Now we have so many screening tests or this CRP, D-dimer, rheumatoid, MAN2, fecal occult blood, BNP. These are used for low risk probability, less serious diagnosis. If a patient coming to me with weight loss and passing the stools, blood in the stools, I don't do fecal occult blood. I go for colonoscopy because FOB is a screening test for low risk, low probability, less serious diagnosis. If I consider the high risk patients, I will go for the high risk for the specific test. And similarly, the spiral CT, some serological tests are all highly specific, and therefore I use them when the probability is high. And I use spin or snout to decide which one I should use. Okay, I use highly sensitive tests to screen low probability diagnosis. I use, and if they are positive, I go for the specific test. If they are negative, I am done. I can be reassured. And highly specific tests, I use them for high risk, high probability serious diagnosis. And if they are positive, I can rule in the diagnosis. And one way of dealing with this is the likelihood ratio. And they say if a likelihood ratio is more than 10, it means that the test is highly specific and you can diagnose and you cannot diagnose the patient. So if the probability, the pretest probability is high or intermediate, you request a highly specific test. If the pretest probability is low, request a highly sensitive test. And in general, you can differentiate. The sensitive test will be positive in so many diseases, right? ESR, CRP, white count, rheumatoid factor, ANA, tuberculin test, FOBs. FOBs can be falsely positive in so many diseases, right? And it's not only colon cancer, right? So you use sensitive tests for screening. They're useful when negative. Use a specific test for high risk, high probability. Okay. Now there is a very nice textbook. You can download it from Google. It's called The Rational Clinical Examination, and I got this table from there, and it has actually written the symptom signs and even the BMP, the sensitivity and specificity. Right now, if I look here, dyspnea on exertion has high sensitivity, right, for diagnosing heart failure, right? So if a patient comes to me, so it is good for diagnosis or for screening, or it is good for screening, not diagnosis, because diagnosis, I need a specific test, right? So if the patient does not have dyspnea on exertion, I can tell there is no heart failure. If it's negative, rules it out, right? Orthopnea is more specific. So if it is positive, it rules it in, right? Same thing. If a raised JVP, if I find it, it rules it in. The BMP is a highly sensitive test. So it is useful when it is negative, right? So when I know that the test is sensitive, it means that it is useful when it is not there. When a test is specific, it is useful when it is there. So presence of crackles is useful. Presence of a pulmonary venous congestion on the X-ray is useful. Presence of raised JVP is useful, and a shared heart sound is the best of them because it has a likelihood ratio of more than 10, right? So this is the best diagnostic one when you see a patient with heart failure is having a shared heart sound, right? These are screening tests. If they are not there, you can be reassured there's no heart failure. These are specific tests. If they are there, then you are sure that this patient has heart failure. Now we go to therapeutic interventions, and it's actually a very simple rule. A very simple rule. Therapeutic interventions. Now, this 5S is an unbelievably simple guide so that you don't miss any part of your management plan, right? It is contextual because you look at the patient and see what is going on and decide on this. It is patient focused, right? What does 5S stand for? S, the first S is the site of care, the symptomatic treatment, the supportive, specific, and specialty referral, right? Site of care, CCU. Symptomatic, patient having pain, analgesia. Supportive, patient needs IV fluids because they are hypotensive, or oxygen because they are hypoxic. Supportive means you're giving something to reverse the abnormal physiology because patient is hypoxic or shocked, right? If you don't give supportive treatment, they will die even before treating their Salmonella gastroenteritis or their malaria, okay? Supportive care sometimes is more important than the specific care, which is antibiotic or thrombolytic. Specialty referral, because in medicine nowadays, you are not allowed to treat your patient on your own. You need other people to help you in caring for your patient. So always multidisciplinary. The 5 S's are simple. Site of care, symptomatic, supportive, specific, and specialty, right? Now, site of care, because you have done your severity assessment and therefore guidelines tell you exactly where you should be treating a patient, okay? ICU for a CARE 3 or more, CCU for acute coronary syndrome.
symptomatic analgesia for pain, antiemetics or antipyretics for fever, supportive IV fluids for dehydration, bicarbonate for acidosis, oxygen for hypoxia, or calcium gluconate for hyperkalemia. Now, these are supportive. If you don't treat these, patient will die, right? And the abnormalities, the physiological derangement become irreversible and the patient dies. So supportive care can sometimes be more important than the specific care. And obviously, every disease has its specific treatment. If there's infection, these antibiotics, thrombolytics for acute MIs or for acute strokes, and appendectomy for acute appendicitis. These are specific. Now, specialty. Now, people miss actually asking their seniors or even their colleagues for help. People have to ask their seniors or their colleagues for help, right? Specialty or subspecialty. Now, this is just an example for our case, right? The bedside diagnosis is recurrent heart failure. And I'm sure that if you give this case to a junior, you tell them this is the history of the diagnosis heart failure. They're unlikely to think the etiology, most likely pneumonia, which is pushing her back to heart failure because she was febrile and she was having pleurisy. So she might have pneumonia, which has precipitated that. The severity of her pneumonia, you can use the curve or you can use NIHAM for the heart failure. Now, if you write the 5 bases, the site of care is ICU, and because her curve score is now 4, okay? And is symptomatic, you have to sit her up because of her heart failure. You might give morphia or sublingual nitrates, and you can use analgesia for her pleurisy. She needs oxygen. She needs specific treatment, IV diuretics and IV antibiotics. And you need to speak to your registrar, for example, or refer her to cardiology or respiratory consultant or educator to help her with her medications and compliance and so forth. So now, for the first time now, if I use this for my patients, you can imagine how great I would feel about my patients. I know exactly what needs to be done. I have a comprehensive diagnostic label and an excellent scheme of care, right? I've tested this in our doctors, residents, right? And we put them for our juniors, and we gave them the case scenario, we asked them to answer, and then afterwards we told them the schemes, but without applying them to the patient. I told them the schemes, and then I told them the same case scenario, you just tell me, is your management plan going to change? And you can see the major difference, right? These are the juniors. These are actually the ones who just completed housemanship, right? You can see none of them at the beginning sort of the severity scoring. None of them. Hardly any sort of a site of care, right? They were good in actually the supportive treatment, but specialty referral, none of them thought actually I need to ask my senior or refer to someone else. You see, just knowing the schemes improves their management plan even without telling them any new knowledge, which tells actually that they had the knowledge, but they were not able to use it because they had nothing cognitive scheme to bring out this knowledge. So the cognitive scheme helped them bring out this knowledge from which was there in their brain. I didn't teach them any new knowledge, but they managed to actually make use of their knowledge when they used the schemes. And this was replicated by seniors. You can see that they did better because at least some of them thought of severity and some of them thought about the etiology, but even in seniors, none of them was thinking about the etiology. You see, it changed dramatically after we told them the schemes, okay? And they thought about specialty referral, but this dramatically improved when they used the 5S scheme. So you can see that just knowing and using the scheme dramatically improved their output, right? They were actually better physicians when they have done that, right? The last part of my talk is assessing for discharge, and assessing is the ACT score. You assess response to treatment, criteria for discharge, and timing of follow-up. Now, these simple things, you assess response to treatment by subjectively and objectively. For example, subjectively, how they are feeling. Objectively, what's happening to the clinical signs, the white count, the crickles. Criteria for discharge, you can decide, well, these are my clinical, laboratory, or radiological, or social. Sometimes social criteria can they look after themselves at home or not. And timing of follow-up, there is no way you can discharge a patient without seeing them, usually within a week of discharge, otherwise your readmission rates will increase, okay? So you have to actually assess response to treatment, put your criteria for discharge on admission so that you know when your patient is ready to go home, and make sure you give them a timing for follow-up to actually assess their disease and see whether they are actually compliant. So in summary, I spoke to you about schemes of care that it will improve our cognitive abilities actually to be more comprehensive in our care and more evidence-based and more competent, right? We have to use history and physical, which have been hypothesis-driven and patient-centered. We need to use technical language when we summarize our history, and this helps us develop our illness scripts or mirror them to our illness scripts. We have to use the best scheme where we label our patients and put the problem list so that our care is holistic. We have to use the APP scheme, anatomical, physiological, pathological differential diagnosis schemes, so that we don't miss any. We have to use the AP scheme, the pretest probability, and then decide on our test based on the spin and SNOUT rules. We use the 5S to put our management plan, and we use the ACT scheme, to answer the question, prepare for discharge. Okay, and I stop here. I finish that. We can then stop the recording there, please, Ahmed.